Good morning, everyone. We're just opening up the Zoom room. We'll wait about a minute as people join. Okay. Good morning. My name is Marianne Roebuck. My pronouns are she, her, and I'm a Director of Integration, Research, and Evaluation here at the Ottawa branch of the Canadian Mental Health Association. Thank you for joining our fourth annual Bright Ideas event, where we highlight the evaluation and research activities undertaken in our organization over the past year. As host for this event, I'd like to begin with a land acknowledgement. As we gather virtually to discuss the research and evaluation activities of the organization, I'd like to ground us by acknowledging that CMHA Ottawa is located on the unceded, unsurrendered territory of the Anishinaabe Algonquin Nation. We recognize the Anishinaabe as the traditional caretakers and defenders of the land now known as Ottawa. We're grateful to live and work on the unceded territory of the Anishinaabe Algonquin Nation. As hosts of this event, we also acknowledge the historical and ongoing colonial research practices that have harmed Indigenous peoples. CMHA makes it our individual, community, and social mission to build connections between Indigenous and non-Indigenous peoples based on knowledge of our history and mutually respectful relationships. We commit to learn, reflect, and take action on our decolonizing journey. This includes in our research and evaluation practices. Before we jump into our agenda, I'll share a couple of technical details. This session is being recorded. The recording will be shared broadly and will produce our annual Bright Ideas report following this event as well. Past reports can be found on our website. The presentations are organized into 3 sections this morning, and after each section, there will be a very brief question and answer period. So throughout the presentations, please post questions in the Q&A box that you'll see at the bottom of the screen. It has a little question mark on it. If we don't get to some of your questions in the events, we will address them later, either directly with you or in our report. And you can also post comments in the chat box, but we'd ask that if you have questions, put them in the Q&A box. And we have French translation for this event as well. So click on the CC box at the bottom of your screen where you're indicating that you want to show captions if you'd like to see the French translation, the live transcript. So without further ado, to provide our opening remarks, I'd like to welcome Dr. Susan Farrell and Dr. Tim Aubry. Dr. Susan Farrell is CMHA Ottawa's CEO and Associate Professor of the University of Ottawa's Faculty of Medicine. Tim Aubry is Professor Emeritus at the School of Psychology, University of Ottawa, and also our very own researcher in residence. Go ahead, Susan.
Good morning. You will notice a delay from my speaking and my sound. We're going to joke because I am currently in Manitoba right now for a reunion, and Manitoba is an hour behind. So we'll pretend that that's what's causing this AV glitch right now. Most importantly, instead of looking at me and the out of sync experience, look at the people on the screen. We are really excited today to have right now 59 people on screen, with more probably joining. So to everyone, I would like to say Happy Mental Health Week. This is probably my favorite day of Mental Health Week, and possibly even my favorite day here at CMHA Ottawa, because today is Bright Ideas. And Bright Ideas is the culmination of a year of really hard work of our staff team, our peers, and our learners. So as you've heard and you will witness, Bright Ideas is exactly that. Wonderful ideas as we continue to learn from people with lived and living experience who team with us as community partners, as staff members, as volunteers, because Bright Ideas is an awesome range of what it represents. A bright range of topics, and all that you'll be amazed at the breadth of what we offer. A range of practical ideas to generate for your teams and to keep conversations going, and most importantly, a range of contributors. The key part of today is the community-based research focus, the participatory focus that allows so many voices to be together and speak about turning bright ideas into research, into evaluation, and into practice. And we continue to live this all year. While it's been a year since we've been together for Bright Ideas, CMHA Ottawa's team of partners, staff, and others have worked really hard in advancing the importance of research and evaluation at our branch and beyond. Two highlights of this are that in January of 2025, we signed a memorandum of understanding with the University of Ottawa to honor our history of shared learning and training, but also to expand our opportunity to work with learners across many faculties. This is a first for CMHAs and a wonderful moment for our branch and our partnership with U Ottawa. And the second wonderful point for us in this past year is we've been working hard to gather hundreds of people's perspectives to shape our strategic plan. That draft plan is still emerging, but what we are clear about is based on the voices and the priorities of everyone, collaborative community-based research and evaluation will be a key pillar in the strategic plan, representing its importance now in what we do and its importance in the future. Because as a community and agency, we embed research and evaluation in all we do, and we strive to make sure it is a key part of all of our conversations. We carry a commitment to collaborate with mental health stakeholders, and we also have meaningful and involved peer conversations, frontline staff conversations, and community partner conversations to ensure we're always working together. So again, happy Mental Health Week. Welcome to the most wonderful day of Mental Health Week. Thank you to everyone who's presenting today and sharing their bright ideas. And thank you to all who walk alongside them to share their voices. And now I'd like to introduce someone who needs no introduction at CMHA, but someone who we're so grateful to have on our team, Tim O'Brien.
Great. Thanks, Susan. You were actually in sync, although I usually think of you as ahead of your time, not never behind. Thanks to CMHA for inviting me and all the students from U Ottawa to be part of this 4th annual Bright Ideas event. I agree with Susan. This is a really special day, and it's a great annual way to mark spring and celebrate Mental Health Week. First of all, I want to acknowledge Donna Petty, the Director of Research and Integration, who created this event. I know she can't be with us today, and we're going to miss her, particularly her regaling us with her sense of humor as the moderator. Susan has mentioned lots has occurred since last year's Bright Ideas event. Most notably and relevant to the research and evaluation at CMHA, our CEO, Dr. Susan Farrell, has taken over the reins since last July. And as a clinical psychologist whose career has been devoted to developing innovative mental health programs at the Royal Ottawa Mental Health Centre, she brings extensive experience to integrating research and evaluation into mental health services. I think the lineup of projects you're going to hear about today demonstrate how CMHA under her leadership will continue to be a national leader in community mental health services research. Another important development that Susan mentioned, and that I'd also like to highlight, is the signing of the Memorandum of Understanding between CMHA Ottawa and the University of Ottawa this past January. This MOU formalizes the important and many contributions that CMHA has in research and training over the past 30 years with faculty and students who originate from multiple faculties, including social sciences, medicine, health sciences, and faculty of arts. Looking over the agenda of what will be presented today at this Bright Ideas event, we see research focusing on the needs of users, service providers, and evaluation of innovative pilot community mental health programs. And I just want to highlight that this is something that's a specialty of CMHA Ottawa. It's getting to the next innovation and doing pilots and then looking to scale it up. There's also research being presented that examines longer-term program outcomes and participation in a knowledge mobilization event from the perspective of people with lived experience. A rich feature of the work you're going to hear about today is the wide range of disciplines from which the presenters originate. This includes public health, social work, medicine, health sciences, psychology, and science. As well, presenters are coming from 4 different universities, notably Carleton University, Dalhousie University, Waterloo University, and the University of Ottawa. And we certainly welcome the folks who are involved from these other universities. Of course, we also have our collaborating research and practitioners from CMHA Ottawa. In closing, I want to highlight that all the projects you're going to hear about today involve meaningful collaboration between researchers, staff, and service users at CMHA Ottawa. It wouldn't be possible to do the studies you'll hear about today without the commitment of agency staff at all levels and program participants. I want to thank them for the important role they play in the research conducted at CMHA Ottawa. Their efforts are helping with the development and improvement of new and innovative mental health services. Thank you. Merci.
Thank you, Tim. Thank you, Susan, our CEO since July 2023. And thanks, Tim, for giving a shout out to Donna Petty. Donna might be here as a participant, so if she was visible, she'd be going like this for all of us to see. So we'll now turn to our first 3 5-minute presentations. To begin, we'll hear from Selena Humani from the School of Psychology, University of Ottawa, and Alison Solar, School of Public Health Sciences, University of Waterloo. We'll make sure you can share there, Selena. Let us know if you need some tech support.
Sorry.
That's okay.
It's showing up with a triangle with exclamation point, so I actually can't see where it's not showing me what to share. Just give me 1 second.
If you like, I can load up your presentation.
The PDF, yeah, I think that'll work.
Okay.
Thanks, Patrick.
Sure thing.
All in a day. This is just part of our...
Bright Ideas is all about teamwork, and we like to make sure we demonstrate that all
right.
across the day.
Absolutely.
Sorry, I think I might have it. Oh, never mind. It's not. Okay, Zoom is not letting me open it. Sorry, guys.
That's okay. If you have it in front of you, Selena, you can... Oh, here we go. Here we go.
Okay, there we go. Okay. Perfect.
Great.
Okay, hi everyone. My name is Selena Humani. I did this for my honors thesis research project with Dr. Marianne Roebuck with the help of Allison. And our research study is characteristics of contacts between people exiting homelessness and their housing first service providers. So we can go to the next slide.
Homelessness remains a significant challenge in Canada, affecting thousands annually. Housing First is offered by CMHA Ottawa for those with severe mental health disorders and chronic homelessness. Housing First provides immediate access to housing without preconditions such as sobriety or treatment readiness. Fidelity to Housing First requires frequent contact and communication between program staff and clients.
We can go to the
You can
next
go to the
slide.
next slide. Over the past couple of years, housing outreach staff have noticed that before clients are housed, a lot of time is spent searching for them, with both less frequent and shorter face-to-face meetings. They also frequently notice better, more consistent contact characteristics and improved quality of care with clients that were housed. From these observations, we decided to look at contact data from within the organization to evaluate differences in contacts before and after clients were housed.
So we can go to the next slide. So the purpose and hypothesis of our study. The purpose was to examine changes in HF contact characteristics before and after housing people with serious mental illness. And we had three hypotheses for this study. The first was that people who are housed will have higher HF program dosages. So that's the number of contacts compared to before they were stably housed 3 months before and 3 months after. People who were housed were going to have longer community mental health visits, so they spent more minutes total 3 months before and after. And then people who are housed will have more in-person, face-to-face contacts rather than on the phone or text contacts compared to before they were stably housed. We also added some exploratory analysis in the middle of the study to look at in search of data, indirect contacts, and contacts with other programs in the agency, such as nursing, concurrent disorders, and peers. We can go to the next slide. So we had 126 clients with serious mental health illness, homelessness, or vulnerably housed in Ottawa. Our study assessed clients' contact characteristics 3 months before and 3 months after they are housed independently in scattered site housing across Ottawa. Using a secondary analysis, we analyzed clinical records of the housing outreach team. And we also used longitudinal data of contact characteristics, which included frequency, length, mode, housing status, mental health diagnosis, and demographic information. We used a bivariate analysis with paired sample t-tests and compared the contact characteristics before and after. We can go to the next slide. So our demographic results showed that we had a majority of a male participant. So 67% was male, 31 female, and 2% was non-binary. Half of our sample were placed in private rentals, followed by social housing at 28%, and then supportive housing and transitional housing. The most common diagnosis was substance use disorder at 51%, and serious mental health symptoms showed up in 71%, schizophrenia showing up in 27%. So now we can look at the results of our hypothesis. So overall, the number of contacts did not significantly increase before and after housing. But we found that face-to-face contacts were longer after housing compared to before. And then we also found that the number of face-to-face contacts were higher after compared to before. So we found two significant results. And we can go to the next slide. So the number of indirect contacts was higher before people were housed compared to after. And similarly, the length of time, minutes of indirect contacts was higher before people were housed compared to after. We also found that the number of clients in at least one other program in the were placed in one other program in the organization, such as nursing, CD, DBT, and peer, and that increased after people were housed. And then we can go to the next slide.
So from the analysis, we were able to draw 4 key conclusions. Firstly, stable housing allows for more meaningful engagement with Housing First program staff. After people are housed, there are more contacts directly with clients. Those contacts are longer, and they are more likely to be face-to-face or in-person. These direct in-person contacts may foster deeper trust and a more effective working alliance within Housing First programs. And finally, increased face-to-face contact and longer visits post-housing could contribute to better client outcomes.
So this is my contact info in case anyone has some more questions as well. And then if anyone has some questions, feel free to ask.
Thank you, Selena. We'll take questions in about 10 minutes after we hear from a couple more presenters. Thank you to Selena and Allison. So next we'll hear from Rebecca Rutland. Rebecca, are you here? Okay, if Rebecca's not here right now, we'll hear from Melissa Arslan.
Hello.
Melissa.
Can
Hi,
you guys
Melissa.
see me?
Yes, we can see you. So I'll introduce you quickly, and while you're speaking, while I'm speaking, you can share your slides. So Melissa Arslan is from the Faculty of Medicine, University of Ottawa. She did a community placement with us, and she'll speak about the review that she conducted. And I also want to acknowledge Sophia Gran Ruiz, our clinical psychology placement student this past year who supervised Melissa's work. So go ahead, Melissa, thank you.
Hi, I just want to make sure everyone can see my screen.
Yes, we
Okay,
can.
awesome. All right, so good morning, everyone. My name is Melissa. I'm a medical student at the University of Ottawa, and today I'll be presenting my research. We did a literature review on cognitive effects of opioid use disorder. There we go. So as we know, Ottawa is in the midst of an opioid crisis. Emergency department visits have really risen since 2017, and this graph shows just that. In 2 years ago, in 2023, we had 207 people die from opioid overdoses, and in most cases, fentanyl was involved. So this data really highlights just how urgent and widespread the crisis is in the city and the importance for intervention. So to support CMHA's work, we conducted a literature review kind of exploring how opioid use and overdose affects cognitive function. We focused on 3 main research questions. The first one being, what are the cognitive effects of non-lethal opioid use and overdose? The second being, how reversible are these impairments and how do different treatments influence recovery? And finally, what new interventions are out there that can actually help improve cognition in people with opioid use disorder? I conducted my search in 2 databases, Medline and PsycInfo. For Medline, I retrieved 636 articles and PsycInfo 446 articles. And I built my search kind of around 3 key ideas. The first being opioid overdose, second, brain injury, and then any kind of cognitive effect. So those are my terms there. And then after removing 223 duplicates, we had 859 studies to screen, and ultimately 35 articles were chosen based on inclusion and exclusion criteria. So this review found that individuals with opioid use disorder do experience significant cognitive impairments across multiple domains. Most commonly, we saw that there were deficits in executive function, cognitive flexibility, attention, and memory. But we also saw slower processing speed, reduced fluid intelligence, and trouble with verbal fluency. So really, that quick adaptable thinking that we rely on for problem solving is really impacted in these individuals. And even when people were abstinent, many of the studies saw that there were ongoing issues with impulsivity and compulsivity. And another topic that really came up a lot was social cognition. So these individuals had difficulty understanding other people's perspectives, reading facial emotion, and also showing empathy. But I think one of the most interesting and relevant findings from this review was that the extent of cognitive impairment was cumulative. And with more lifetime overdoses, it was linked to more severe deficits. So this really highlights the importance of early interventions for these individuals. And then when we looked at pharmacological treatments, there were some mixed results, but overall treatments like methadone and naloxone could really improve cognition, especially in the first few weeks. We saw the improvements in executive function, attention, and memory, but that being said, there were still some deficits that were persistent, like with compulsivity and impulsivity. We also saw that during early detox, cognitive deficits were really widespread and prevalent, but with long-term abstinence, many people recovered to near normal function, which is really good news. And then the last thing we kind of looked at were new therapies, and what we saw was that a lot of people now were combining, or a lot of studies were combining pharmacological treatment with cognitive remediation. And with this, we saw higher remission rates, reduced cravings, improved memory, and also lower opioid use. So even, I need to mention, even a mindfulness program, so the MORE intervention, which was like an 8-week mindfulness-based program, showed benefits for these individuals. So even small things like that can really help alongside pharmacological treatment and could be implemented to benefit them. So based on these findings, there are several takeaways, but first, really, I would recommend integrating cognitive remediation strategies into pharmacological or other types of treatments. Programs should also be adapted using visual aids, simple language, and memory aids to kind of help with the efficacy of these programs. We could also encourage mindfulness practices, but really we should aim for early intervention and making these services more accessible, which can really benefit for people with opioid use disorder. And last thing, always encouraging research on cognitive dysfunction to kind of see what new treatments or what new methods we can implement can be really beneficial. So thank you so much for listening. And if you have any questions, either at the end during the question period or my email is also there. I'd also like to acknowledge Sophia because this project would not have been possible without her. So thank you so much for that. And also the librarians that helped out.
Thank you, Melissa. Thank you for such practical, usable recommendations from your work. We appreciate it. And now I'll turn to Rebecca Rutland. We had the privilege of having Rebecca Rutland, one of our peer workers, do a research placement with us as part of her MSW degree at Dalhousie University. So Rebecca will share about her research during her placement with us.
Thank you. I'm just going to pull up my screen and hope that happens the way it's supposed to.
Looks like it. Thanks, Rebecca.
That is a good thing. Okay, so although it does look like I may have lost my notes in the process, so we'll see how that goes. Okay, so for my MSW placement, just quick thanks to Marianne as my supervisor, as well as Teresa Millenstein, one of our program managers here, who helped out quite a bit. The project I did was the development of a discharge planning 101 training at CMHI, a qualitative study. Too many things on my screen. So the background, in the Ontario Perception of Care Survey Blitz in 2020, it showed that 18% of CMHA Ottawa clients reported that they wanted improvements in their experiences with graduation, so a pretty significant amount. 2024 needs assessment by Chute Hayes done at CMHA looked at discharge practices and strengths-based intensive case management and suggested again that a staff training be implemented. And there was also some additional evidence for discharge related improvements supported through organizational process mapping and data analysis of client length of time and service. In addition, CMHA Ottawa is undergoing accreditation review in the upcoming cycle in winter 2025, and we have some current quality improvement efforts the branch underway to improve our discharge practices. So lots of reasons. The purpose of the study. So in the early explorations of solutions, we began theorizing more that increased staff knowledge and skills might help shift towards improvement in discharge process. And the purpose of the work is to uncover the challenges, gaps in knowledge and skills needed among direct service staff, as well as uncover service users' attitudes, needs, and challenges in graduation, and identify the components that we might want to address should a training be developed. It was also hoped that some of the groundwork done for the training would help reveal some gaps in process and knowledge, including in client care flow, documentation, and understanding why clients may remain in service for extended periods of time, as well as some of the hesitancies and issues and challenges that workers are experiencing. So we reviewed 11 peer-reviewed articles, notably only one article specific to discharge planning from community-based mental health care environments to independent community life without any kind of formalized services was found, and that really showed a lack of investigation and information in this area. We reviewed some internal organizational and some external documents, such as the Chute Hayes needs assessment and the 2021 process mapping by hesitance, and a series of consultations with CMHA staff. So that included 4 individual program managers, 3 individual case managers, and 1 direct service team of 8 that was consulted as a group. And the service users consulted included 3 individual clients, and the peer engagement advisory committee was also consulted as a group. And then some further information was gathered through more informal conversations and some of the author's observations. We used a pragmatic descriptive approach as a qualitative data analysis method, and that was applied to gather the information from the studies, which was then organized into cross-case matrices. So one matrix to organize the literature and a second for consultation. And the summaries distilled from these revealed the key information that was used to inform the development of a training module, and a brief narrative report was generated that was also used as scaffold for the training development. So we identified some broad themes for the training content. One of these included clarifying organizational concerns in moving clients through service and ensuring staff were aware of these. So that included quality improvement efforts, accreditation standards, and service flow needs. We also found case management and principles and practices to be included. So really highlighting that discharge planning starts at the beginning of service, and it's a reflection of the entire sort of lifespan of the client's involvement with CMHA, and is a reflection of recovery-oriented, person-centered, and trauma-informed care principles. So the idea of throughout the life of the case of doing with, not for, the client to build towards, build self-determination, build choice, including the right to risks and the right to fail and grow. And that was really endorsed by the clients who were consulted, as well as that transparent communication about case management not being a forever service, and that conversation needs to start as soon as possible in case management services and continue throughout as an element of informed consent and setting clear expectations. Really emphasizing that graduation, the whole process from the decision of when it occurs to how to celebrate, needs to be done with collaboration with the client and discussed again at regular intervals. And also really overall supported the idea that structured service plans with checklists for goals and sort of inventories of unmet needs are really important in kind of moving through case management services and working those successes and making sure that people are really clear on the goals that are still outstanding. And then finally, the relational elements of case management really shone through as being very important. Case managers work very, very hard at establishing alliance, and we do work with people here who can be very difficult to form trust with. So it can be a really challenging length process for both the worker and client to form that relationship and then to let go. Finally, there's evidence that the relational aspect of services is of particular importance as a component of cultural competence. So for some of our clients of Indigenous heritage, for example, healing might actually occur through the relationship, so that can't really be devalued. And a final note that even for clients who don't engage extensively with services, it can still be hard to let go. So the conclusions we came to were that a training was determined to be an asset for improved discharge practices. The report that was generated was used as the scaffold for the base for the training based on the 3 overarching themes identified, and then the sub-themes that we included: prioritizing collaboration, self-determination, the right to make mistakes, workers doing with, not for, was all included within that training and became quite a meaningful component of it. And I just want to sort of mention one of the things here in communication was that came through was also making sure that we use really strength-based, person-centered language. So for example, we use the term graduation versus discharge in the training itself. Knowledge mobilization. So we created the training, Graduation 101. It was piloted in December 2024, and feedback was gathered for improvements. The training is being implemented. It's being sort of improved based on that feedback, but it's being implemented in our regular training schedule. We're going to continue to monitor data regarding rates of discharges to determine any impact. And there is also a Graduation 101 co-produced course in development at our recovery college. So that's with some of our service users so that we can make sure that we're also kind of mobilizing knowledge and informing and creating a bit of a 360 understanding of how graduation works at CMHA. And that's it.
Thank you, Rebecca. Thank you
You're
for your work. We appreciated your social work research perspective throughout this project and how you were self-reflective and reflexive when it came to your position as a researcher. Thank you for your contribution. We'll now take some time 5 minutes to look at our questions and answers box, our question box for the 3 presenters who've come before us already. So the first question that we have is for Rebecca. Rebecca, how do we assess readiness for discharge at CMHA Ottawa?
Okay, great question. So that was where the information we uncovered on that need for sort of very clear service planning, including checklists and guideposts along the way. We didn't really uncover any kind of actual process that I could really recite towards discharge, but some of the ideas that came up were surrounding waiting until when a client gets to about 85% of their remaining goals, that's a really good point of assessment to determine if those unmet needs are ones that really the most appropriate place is CMHA, or if the client might be able to kind of learn to do those on their own, or if there's community resources or maybe another resource that's even more culturally appropriate for the individual. So that's something that we're working on, and that really came up a lot during the actual the pilot where people asked about that. So again, going back to that idea of the 85% marker, as well as introducing the use of some of our tools like the I'm forgetting the name of it. Some of our like strength-based and the PRP, some of our and the OCAN as well,
Mhm.
the Ontario Common Assessment of Needs, towards using that to continuously measure where people are at and kind of get a pulse on things. And finally, assessing readiness. The best way to do that really is ask the client and empower clients to be able to have that discussion and come to the worker to talk about when they think they might be ready to go and respecting their decisions.
Wonderful.
Yeah.
Thank you, Rebecca. And then we have someone who's expressing interest in the Recovery College course, so we'll make that connection. And
Okay.
then, and a question for Melissa. Melissa, do you have any recommendations for simple cognitive remediation practices that could be done with clients and/or options for agencies or organizations that provide training and resources for this?
So most of the cognitive remediation that was done through just computer programs. So kind of depending on which deficits were more prevalent in the individuals, that's what they worked on. So even like simple tasks, like computer tasks that work on your memory or that work on like your attention. So simple card tasks, stuff like that, really showed to be like to have a big difference for these individuals. So it doesn't really have to be like seeing a professional and then, like going to the hospital, something like complex like that. It can be even just when you go to a community center or you come to see someone from CMHA, like just spending a bit of time, 15 minutes every day, doing this small computer program or even on sheets. It can be something as simple like that. And it has been shown to really help with cognition. And the links for my study are in the references of the QR. So even if you go like through those references, that can give a few more ideas. But yeah.
Wonderful. Thank you.
Yeah.
Okay, and then, oh, this is following up. Did you find that seeing an OT was included when it came to best practices in cognitive remediation?
I didn't see anything in the studies that I screened, but my search strategy was specifically on cognition. So there wasn't like physical therapy included in the search strategy. So I might have missed studies that did look at that. So it is something to kind of investigate further, but I didn't see anything there.
Great. Thank you. We have interest in our graduation 101 training from another branch, which is awesome to hear. That's one of our goals for this event is that we'll be exchanging knowledge with other branches. So I have one question for Melissa. Something that we are looking at is, well, obviously we house people who use opioids, and you mentioned that long-term, when people who are using opioids have long-term abstinence, you see positive results. Did you see any timelines around what long-term meant there? Because we find, yeah, go ahead.
Um, I would have to go back and look at the studies because there were quite a few that mentioned that. I think it was at least 2 years that was
Hmm.
considered long-term, but
Yeah,
there was one specific study that looked at long-term abstinence, so I would have to go back and kind of see that and get back to you. But from what I
great.
remember, it was at least 2 years of long-term
Okay,
abstinence.
good to know.
Yeah.
Thank you so much.
But from like just from a few weeks, you could see improvements in cognition, which is awesome, really, to see.
Yeah. Okay, thank you.
Thanks.
So we'll now turn our attention to our 4 feature presentations, profiling some research advocacy we were involved in this year, 2 studies on new housing interventions, and an evaluation conducted with our diversity, equity, and inclusion committees. We'll start by hearing from Erin James and Ryan Vachon, 2 of our Peer Engagement Advisory Council members, with Tim Aubry and Susan Farrell. Go ahead, Tim.
Thank you, Marianne. This talk to you about a knowledge mobilization project that a number of us were involved in. It was actually something that it was the Mental Health Commission of Canada, to give you some context, put together a day-long forum prior to the beginning of the Canadian Alliance to End Homelessness annual conference that was held in Ottawa at the end of October last year. And the purpose of the get-together was to try to reboot Housing First. You know, our estimates, that comes from the Canadian Housing First Network, is that there's about 80 to 100 Housing First programs across the country, which is good, but we know we need a lot more of that. CMHA Ottawa has one of the biggest Housing First programs in the country, and knows very well how effective it can be and helpful to people to help them end their homelessness, but also get involved in the community beyond just being stably housed. So this was a chance to look at where are we? We talked about the research base, which is extensive. We also looked at where there were knowledge gaps, because the approach keeps evolving, and we have examples of that right here at CMHA Ottawa, in terms of some of the pilot that's being run, known as Full House. And then we looked at policy and practice recommendations. What should we be doing going forward? And particularly, how can we grow Housing First nationally? And it was great. Ryan and Aaron were there, as well as Lisa Med and Susan. And we're going to hear today about Ryan's and Aaron's kind of experience being there. The Mental Health Commission of Canada values, and I say this, genuinely values the input of people with lived experience. So there were a number of people, there were 65 people there, just to give you an idea, and they really tried to get representations from different groups, as you can see here on this slide, including people with lived experience. So what I'm going to do is ask some questions, and Ryan and Aaron will provide a response. Questions that try to get at what did they think of the session? How did they see it? What do they see as the value of it? So the first question, what were the main messages you felt were important to share during this consultation day? Maybe start with you, Ryan. Oh, you're muted, Ryan.
Yeah, I'd like to say that it was an honor for me to be able to attend last year's conference. First of all, with so many attendees from diverse backgrounds, I felt welcome and encouraged to share my own perspective as a person with lived experience of homelessness and mental health challenges. Having experienced periods of homelessness for several years, bringing an end to homelessness in Canada is an issue that is very close to me. Today, as a person with lived experience, I feel it is necessary to tell my story where possible, not merely in hope of reaching others, but to aid in my own continuing recovery. The experience of homelessness isn't only about being deprived of adequate housing, it's also about being unseen, unheard, and so often judged before anyone knows our story. Our stories are not just anecdotes, they're real evidence from real life. Through our lived experience, we come to know what works and more importantly, what doesn't. We've seen the gaps in the system up close. We know the stigma, the red tape, and the silence that surrounds homelessness and its deep-seated causes. We understand the emotional tolls of being unhoused, the barriers to recovery, the devastations of ongoing systemic oppressions. But we also know the value of dignity and trust in our continued recovery. Today, we face the dire reality of a housing crisis that demands urgent action. Solutions cannot come quickly enough. We know that many people experiencing homelessness are dealing with acute trauma, substance use, and other mental health related challenges. As a society, we cannot aid in the recovery of people until the basic human rights for housing have been met. We often forget that homelessness is a scourge that affects all of us in some way. Truly, it can impact any one of our neighbors. There's no such thing as a typical person experiencing homelessness, and no one is absolutely safe from experiencing it. As we all face unique challenges, this crisis cannot be solved with one-size-fits-all solutions. There are no shortcuts that can be made towards a greater recovery of people. The transition out of homelessness demands time, patience, and understanding. It's about resilience and recovery. Thank you.
Okay, addressing housing is vital and should be a human rights issue and a health concern, and therefore the determinants of health language could be used in reporting. The availability of affordable housing, supportive landlords, but also integrated services to ensure that mental and physical health concerns are addressed needs attention. The mental health concerns of people with mental illness coming off the streets need to be addressed by integrated services like ICM and ACT teams. It should be accessible since the experience of homelessness can be mentally draining and physically disabling. Support for tenant-landlord issues needs attention as well. Breaking down the silos and person-centered care, where I've been empowered to take on my health, has been vital to my own housing and recovery journey. Integrated services where service workers collaborate is important in housing first and it should be highlighted. Housing stability has been vital to my mental health and my capacity to move beyond isolating towards taking more active steps in the community. I'm currently actively volunteering at a bunch of agencies.
Great, thank you, Aaron and Ryan for those powerful messages. We'll turn to the next question. What's important at events like the ones you attended on Housing First consultation when it comes to having meaningful involvement of people with lived experience like yourselves? Ryan?
Sure. Too often, important decisions surrounding homelessness are made without consulting those who've lived or continue to live through it. If you want to have a meaningful conversation on ending homelessness, we should also begin by consulting those with lived or living experience. When we involve people with lived or living experience in consultation, we bring real-world insights of people who best understand the traumas of being unhoused and have a firsthand awareness of the pervasive barriers to recovery that exist today. Barriers not just to stable housing, but to the dignity and health of us all. The perspective of those with lived and living experiences bring credibility, compassion, and sound solutions to homelessness that are grounded in reality. lived or living experiences, lived or living experience bridges the gap between policy and people. It can help shape policies that are more practical, humane, and ultimately more effective in identifying systemic barriers to recovery that may not be apparent to policymakers. People with lived or living experience bring in critical insight that policy alone cannot truly replicate. Combating homelessness isn't just about more affordable housing, it's about resilience against ongoing systemic oppression. Greatest force of oppression is silence. Sharing our personal stories with others aids in reducing stigmas that persist today. Our perspective as people with lived or living experiences help to ensure housing and social supports are trauma-informed and culturally appropriate. When we value lived experiences as expertise, we create more compassionate, inclusive, effective systems that encourage health and growth. In doing so, we might begin to move closer towards ending homelessness and its causes instead of seeking immediate band-aid solutions as we currently do. Ending homelessness requires more than making reforms to our services. It demands the empathy and leadership of those who survived it. Thank you.
Thank you, Ryan.
Uh,
Aaron, go ahead.
Honestly, I don't like talking openly about my experiences with homelessness and acute psychosis with the resulting self-harm behaviors, particularly when I went off my meds. However, as people with lived experience, it's really important we tell our stories, at least the stories and narratives we wish to share. Sharing our stories is key in so many ways to developing urgency, strategies, and priorities for research, policy, and practice, as I've discovered with PIAC. It also gives us courage to heal and move beyond the pain and social isolation associated with anxiety, mood, and psychotic disorders. There's still a great deal of stigma around talking openly about mental disorders. Most people won't admit to mental illness, and social discourses still construct negative identities around mental illness, even though identities should be similar to those associated with diabetes or high blood pressure. Similarly, everyone experiences mental health. On a continuum, some have acute symptoms. Recovery is possible. We still construct self-other dualisms around mental illness. Madness in North American culture gets associated with homelessness, crime, poverty, vice, wars, and disabling medication. The self in this case is properly housed, working well off, clean and healthy. As a note, similar dualisms were constructed around Chinese Canadians in the early part of last century as lazy, indolent, and bearer of crime. Media will daily reproduce such self-other dualisms in reporting stories and accounting for mental disorders such as injustice reporting. We are left with a very visible construction of otherness around people with mental illness. Similarly, agencies affecting our stories is traumatic for some people to talk about openly. Should be careful not to re-traumatize clients, as a colleague of mine recounted after she reported her story to the media. Clinical information should be left to psychiatric services. Thank you.
Great. Thank you, Aaron. Thank you, Ryan, for your insights. Just in terms of in conclusion, this forum is producing a report that tries to capture what went on during the day, the kind of messaging and perspectives like we heard today from Aaron and Ryan, but it does include recommendations. The report is not out yet. It will come out in late May, and maybe you can leave your email if you want to get a copy, put it in the chat. I'll just tell you quickly what the key recommendations were. And I have to say, they're really in line with what's already going on at CMHA Ottawa. The first one is just helping our group of Housing First programs across the country, and in particular to develop a way of capturing information about who they're serving, their services, and their outcomes. You heard today from Selena, analysis of data, a database that CMHA has around its services, certainly including its Housing First program. The second recommendation, and again, CMHA Ottawa does a lot of this already in our community, but it's really trying to improve the training and technical support that we provide to Housing First programs to people who are involved in Housing First programs. The third one is really to come up with a strategy, and we know this, it's a huge issue in Ottawa, to advocate along with others in the sector that provides services to people who are homeless. We need more deeply affordable housing. And that we heard from people who were there for the different perspectives that this was important, but we also need, because we are doing that to some extent in Canada. There's a lot of building going on. The new government says it's going to accelerate the building of new affordable housing, but we can't forget the supports. And in particular, the supports that include health services. And then finally, we need to do advocacy. We really need to champion Housing First out there. Housing First works. There's an extensive research base, and it's really actualizing the right to housing. That's what for me is so meaningful, and why I put my efforts into really trying to grow Housing First in our country. And we are seeing this is going on elsewhere and across Europe and so on. So it's really important that we continue to do that. And again, CMHA Ottawa is a leader in advocating for Housing First, both locally and nationally. So to end this session, I'll turn things over to Susan, who will talk about how CMHA will go forward with advocating and growing Housing First.
Thank you. Thank you, Ryan, Aaron, and Tim. When I have the opportunity to go to consultations, be they national like this, community-wide, or others, I always introduce myself as the proud CEO of CMHA Ottawa. But I was particularly proud to be part of this event and to consider myself part of Aaron and Ryan's team as we had this wonderful day with the Mental Health Commission. It's a good question. So we're going to get a report in May. What does that mean? What I want to do in just a moment, because I'm mindful of time, is underscore exactly as Tim said. The staff team, the peer team, and others at CMHA Ottawa is committed to Housing First. Most importantly, to growing it through the ongoing collection of data, through the innovations like Full House that you're about to hear about, through weaving in the experiences of people with lived and living experience and people who provide services, and what we continue to learn each day, but also what we learn from each other. I am in Winnipeg right now for other meetings, but I'm going to spend this afternoon with CMHA Winnipeg, who does some really innovative work in Housing First, to bring some of that back so we learn as a broader community. So CMHA Ottawa is giving its full commitment to not only implementing Housing First, but to learning about it from the shared experiences of others and continuing to contribute to the research and evaluation. And having folks like the team today just make us very proud in how we go forward together in care and in advocacy. Thank you.
Thank you, Susan. Thank you, Aaron, Ryan, Susan, and Tim, especially your powerful words, Aaron and Ryan, and your grounded insights. We'll now turn to a presentation on Full House. We have Dr. Christina Muchler. Christina has been our postdoc researcher for the past 2 years, and we acknowledge the work that she's done very, very much in close partnership with our frontline staff. And joining Christina are Mick Phipps and Marcella Farias, 2 incredible housing outreach workers that we have here at CMHA Ottawa.
Awesome, thank you, Marianne. Do you see the presenter view or do you just see the slides?
We see the presenter view.
Okay.
Everybody sees my conga line before I say it, y'all.
Okay, let me do this another way then.
Perfect.
Better? Okay.
Yeah.
Perfect.
Thanks, Christina. All right, good morning, everyone. I'm Marcela Mbofrias, and I'm happy to be with you today, introducing our presentation on the Full House Initiative, an implementation of Housing First with individuals with severe opiate use, alongside my brilliant team members, Mick Phipps and Christina Muchler. Awesome. So the Full House project would not have been possible without the hard work of the entire greater team here at CMHA, who are really dedicated to housing individuals who can at times be the hardest to reach in our communities. So this includes our colleagues from our concurrent disorders team, our nursing team, our housing outreach and support, and our research and evaluation teams that are shared here. All right, so this morning we will be discussing our project, which focused on the housing process for individuals who are experiencing complex substance use, primarily of opiates, while also living with mental health, physical health, and other determinant of health challenges. We will overview a bit about the Housing First model used at CMHA, and then discuss some of the obstacles of using this model with the folks our project supports, before diving into an overview of our project, explaining how we attempted to address these obstacles. We will then discuss the evaluation of our project, including our successes, our challenges, and ending with some next steps we've developed for future. All right, so CMHA follows these listed principles here of Housing First model when providing housing and case management supports to our clients. It's also important that we highlight here that our organization was found to have high fidelity to the Housing First model upon evaluations. And I will turn it over to Mick.
Hi, I'll be speaking a bit about those challenges in housing for folks using substances. Let's look at a little bit of research first. Some things we know or we have good evidence of is that folks who are using substances tend to spend less time in stable housing. We also know that that's true even when some of their other life domains aren't affected necessarily. And that research suggests that we could and should focus on health outcomes while we're doing housing first, which is what we try to do here. So how does that substance use impact housing first efforts? The first is it's highlighted when we're actually looking for housing, trying to access housing. Housing is already limited and hard to access. And then folks who are using substances face additional barriers to that. We also find that accessing services can be challenging for folks using substances. Those harm reduction services that they might benefit from are often concentrated in some areas and not found in others where they might be moving to, and they might even be completely non-existent. We've also found that one of the main challenges is connecting with folks. An earlier presentation here highlighted that beautifully, connecting with folks while they're out and facing those challenges around substance use makes it really challenging to connect with us in a meaningful way. That is highlighted once again when we actually do find housing. Finding housing means that there's a lot of steps to go through around lease signing, gathering IDs, moving in, preparing the space so that it's safe and comfortable. That takes a lot of effort, a lot of time. That's challenging to do when you're facing some of those barriers and using substances. And then there's making connections. Oh, it's just the last line, just making connections with your community. Just like services are concentrated for folks who are using substances, our communities might be concentrated around some of those activities and don't necessarily transfer or translate to another neighborhood or to the new place you're moving to. So how did we develop this project? We're going to go through that here. We'll talk about the designing the project, some of the activities that we do, the adaptations, what makes this different than our regular housing first approach. And we'll talk a bit about the clients who are involved, of course. So we were trying to answer a question. It seems simple, and we're still working on developing that answer. But how do we deliver that housing first approach with folks who are experiencing these additional challenges around substance use? And what we tried to do was a collaborative approach. So the idea was to gather around a table, gather a multidisciplinary team, lots of experts, and we actually started gathering around that table before we knew what we would actually do around that table, which was interesting. And oh, yeah, and so that's how the project was developed. It was developed as we went, as we figured out how housing would work for the people who would be moving in. So we also involved the clients right away. There's 10 individuals that we worked with. All were experiencing homelessness. All were involved from the very beginning, and as we were figuring out what we might be able to do with this project, we started looking for folks who might be interested in participating, but also having their say in how this would move forward. All the folks involved were experiencing homelessness. Some were unsheltered. We tried to focus mostly on folks who were struggling to access shelter or services in a traditional or regular way, and all were actively using mostly opioids, but lots of other substances as well. That's how we work towards that objective of applying housing first, and using all of those best practices for substance use and harm reduction.
Mhm. Back to me, I think. All right. Well, I'm really glad that all at the same time, everybody asked what made the Full House approach unique. So I'll speak a little bit about that. We built on our existing partnerships to quickly secure housing in our project in areas where each person felt safe or comfortable when possible. We handled all of the initial housing logistics, from covering first month's rent to making sure that there was food in the fridge on move-in day. We also advocated for our participants to be able to have a more secure place to stay before their housing was ready. So a form of respite, whether that was at a hotel, in a hospital, or even securing a consistent bed placement in a shelter. And this was an effort to decrease instability and promote rest and wellness before their moves. We also provided holistic support right from the start of referral. So as Mick said, we all gathered around the table right from that point of referral and continued that support through, especially focusing on those critical first days in housing when things like loneliness or unwanted visitors often come up. And lastly, unlike our traditional models where one housing worker collaborates independently with one individual, we committed to working as a team, which really allowed for quicker and more responsive support and more room for creative and collaborative problem solving. All right, so take it from our participants and less from us. We have some quotes that were shared and how those adaptations changed for our participants' experience. So for the first time, it felt like people were working with me, not just telling me what to do. I wasn't dropped even if I missed an appointment. They kept checking in even when I was struggling. And the team made sure finding a place to live and my recovery were both a priority. It wasn't one or the other. All right.
Okay, perfect. Thank you too. I'm going to speak a little bit about our evaluation. So some program evaluation and outcomes. Then we'll talk a bit about our achievements with Full House, as well as some challenges that came up. And then we'll speak a bit about next steps for the project. So this is just our dashboard, our beautiful dashboard of our Full House clients. The majority of our clients, we had 10 who were successfully housed, and 70% are female. The majority speak English. The age range was between mid-30s to mid-60s. The majority of clients were identified as white, although we also had 4 Indigenous clients in the program. And then all had a substance use disorder, which makes sense given this was the client population we were hoping to work with. And then many had other additional diagnoses as well as chronic medical conditions. In terms of client characteristics, this group of 10 clients that we initially piloted the program with were very complex in their needs. So you can see that 100% of these clients had problems with substance use, with relationships. They all had housing as a current need, as well as financial concerns. That being said, the majority of them also had, above and beyond that, a variety of very complex needs, histories of trauma, histories of difficulties in the legal system. So a very complex presentation of clients that we were working with, trying to house. In terms of our program outcomes or our successes here, all 10 clients were successfully housed with no eviction notices, despite having ongoing substance use. Two of those clients have maintained housing for over a year now, which is just amazing. It's so exciting for those folks. And two clients transitioned from residential treatment into independent housing as well. All clients are actively engaged in substance use support, whether that's harm reduction or abstinence or sobriety, if that's what those clients are choosing. 8 of them are participating in a safer supply program, and 2 of them are maintaining their sobriety. In terms of the actual client engagement, what we found, and I'll show this on the next couple slides as well, is that as soon as clients were brought in to the Full House program, what we saw is that their engagement with the providers on our team went up substantially. So there was more consistent communication and engagement and a more diverse set of activities and treatment plans and providers that our clients were seeing. So this is one example of one of our clients in the program. And I'll just explain this graph a little bit for you. So you'll see the little house in the center there is the moment when this individual entered the Full House program. So you'll see before then, they only had client contacts, which are those little orange dots, with their primary worker. And you'll see below that are what we call at CMHA as in search of. So these are times when the primary case manager was trying to find the client, but wasn't able to find them in the community. So those are the only contacts that that client was having in our system at CMHA. Once they were housed, you'll see that they began to have contacts with our concurrent disorders program, with nursing support in order to get primary health care, as well as peer support. So once they entered the program, they got better access to all these services because we had them right on the team, and they were much more engaged in their care. This is another example of that. You'll see the little house there at the bottom, and just visually you can see how the differences in the contacts changed for this individual. So for this person, they were really relying on that nursing, that primary physical health care. As soon as they got their housing, they were ready to go and engaged with harm reduction and that physical health support. So just a huge shift here, right, in terms of the what clients are accessing. So I also just wanted to note that the Full House team did a housing first fidelity assessment. This was conducted, it was a self-assessment, but conducted by Marianne Roebuck, who graciously offered her time to help us with this. And so we self-rated across a number of the Housing First domains. And what we found was that the program had high fidelity across all domains to the Housing First model, which is really exciting. And we were also able to note some of the adaptations we made in this process. So some of you might be familiar with the ACT model. Of Housing First. And what we found was that our team, based off of the fidelity assessment, we do some operations like a intensive case management program, but we also do some that are more in line with an ACT model, where we very much work as a team, and every provider has a role for a client's care. Okay, I'm going to hand it back to my two wonderful colleagues.
Thank you. I'll speak about, I'll highlight some of our successes. There were many. The main one that we found was that stabilization period just before housing. Remember, this wasn't a requirement or transitional housing. It was finding opportunities for clients to increase stability just enough to be able to access housing. The increased engagement, which we saw beautifully on those graphs in the previous presentation as well. That dedicated team support. The people around the table represented the same services that most clients can access, but having them directly there focused on each of the 10 clients once a week was the real difference here. And that collaborative focus, all those dots as the primary worker, when the rest of the team comes in, meant that I didn't have to be everything to everyone at all times. I was able to work with a team, diversify the kind of support that we could provide.
And of course, anytime you do anything for the first time, you're bound to learn a few new things. And that's definitely been true for us at Full House. So one of the biggest challenges we ran into was the limited housing options available. Affordability and accessibility are still major issues, especially for folks without rental history, landlord references, guarantors, and the stigma that they face because of homelessness, mental illness, or substance use. We also observed something that we've termed here as persistent homelessness, where some of our participants continued sleeping outside or in shelters even after getting housing. When we looked more into it, we found that sometimes, despite our best efforts, the transition wasn't always smooth. For instance, some challenges arose in the resource availability in the communities that folks were now in versus the communities they came from. So like not being near a pharmacy that dispenses methadone or having access to safer use supplies, making it harder to fully settle in. Related to this was the ability to build community. We noticed that even when folks moved into familiar neighborhoods, it was sometimes still tough balancing the old community they belonged to while living unsheltered with their new housing circumstances and change that we were trying to build around. In some cases, this also led to not returning to their units at night. And finally, we learned a few things on the logistics side. Working as a collaborative team did increase the workload in a different way than more traditional approaches. We also realized how important it is to plan for transitions, making sure that our folks can move from our support into long-term community services without hitting any bottlenecks. What's next, Mick?
What's next? Well, what's next is actually already happening, which is exciting. Streamlining referrals. So once we've worked with those 10 initial people, who are the next 10 and the next 10, and how does that flow through the project? So we've focused on transfers and closures, and those are already happening. Building sustainable partnerships. This I mostly think about better ways and more sustainable ways to build in that respite or stabilization period with support from the city or other housing providers. Replicating the model, we start thinking about who else or what other teams could be gathering a table the way we did, and what do they need in order to do so. Community engagement, that's the idea of considering those neighborhoods that I described as a harm reduction desert, finding ways to involve local clinics and pharmacies in providing the supports that folks need. Feedback loops, getting all kinds of good feedback constantly and responding to it and sharing it, especially coming from the participants and the tenants in this program who had an opportunity to share and co-create in some ways along the way, but there's still loads of room for more involvement. And that's what's next.
Thank you. Thank you, Mick, Marcella, and Christina for your work and for your wonderful presentation. And now Christina will begin her second presentation on community building social prescribing with Elise McCall-Thomas.
Okay, awesome. Oh, there you are. At least your name is Marianne on the screen. Okay, perfect. It's like, oh no, where are you? Okay. Everyone is stuck with me for one more presentation, so I'll just pull my next set of slides up.
Thank you again, Christina, for your meaningful research with the organization over the past 2 years.
Of course. Okay. All right. Okay. Well, thank you so much, everyone. I'm Christina Muchler. I'm joined with my colleague, Elise McCall-Thomas, and we're going to be speaking to you today about our community building project, which I love. It comes after Full House because it really, we've talked about how it's difficult for folks to integrate back into the community once they've obtained housing. And so we hope that this is a helpful approach for going forward. So we'll just briefly, we'll touch on what is community building. We'll talk about our program objectives. We'll speak about our formative and outcome evaluation. And then I will also briefly go through with you today our community building toolkit, which we've created that I'm going to try to send in the chat today so that everybody can have access to that if you're interested in implementing community building in your own organizations. Oh no. Elise, are you? There you are.
Yeah, sorry. So I'll try to go over this relatively quickly because I know we've probably talked about it in the past, but maybe for those of you who want a refresher or weren't here in previous presentations for the Bright Ideas conference. So what is community building? So really in this case, what we've defined it as is a combination of social prescribing, so connecting people with community resources to address social needs, and citizenship, so connecting people to rights, responsibilities, roles, resources, and relationships in society. And really this, the idea of social prescribing or community building is that it may lead to participation in the community activities, increased community integration, which would lead then to increased sense of belonging, quality of life, recovery, and just reduce feelings of loneliness overall for individuals who are engaged in community building. So what we did is we took this notion to develop our project objectives, which were first to identify the needs of clients in the Housing First programs, then develop our intervention, then pilot the intervention, and now we're sort of at the end, which is implementing our knowledge mobilization strategy. So what did we learn from this intervention, and what can we share with others who might be looking to implement it in their own Housing First programs? So in terms of, we conducted 2 evaluations as part of this project, a formative and an outcomes evaluation. So we'll start with the formative evaluation, which is really an evaluation that's conducted either during the development and or the implementation of a program or an intervention. And really what a formative evaluation does is it gives us real-time information about what's working well or not working well with an intervention so that we're able to course correct in its design or implementation, really to try to improve the overall effectiveness of the intervention. So instead of waiting till the end and learning about what worked well and what didn't work well at that point, we're able to do it while it's being implemented. which is a great learning opportunity for all those involved. For this formative evaluation, we engaged in several methods of data collection, including focus groups with CMHA staff, interviews with Options Housing staff, client interviews, as well as we use notes from a community of practice with case managers, and then notes from lunches with clients, which I'll talk about in a little bit. So in terms of, as I mentioned, formative evaluation gives us a chance to learn about how an intervention is being developed and implemented. And so one of the questions we had is the intervention being implemented as intended? And really to help us learn about this, we really leveraged the notes from those community practice meetings with case managers. So they happen on a monthly basis for a couple of months during the course of the intervention. They were well attended by the case managers, and thank you to those of you who might be on the call who attended, shared with us, your experiences with the implementation of this intervention, what was working, what wasn't, so we were able to learn, and for other case managers to also learn from your experiences. And then we also leveraged the notes from the lunches with clients, which again occurred monthly several times throughout the course of the intervention. Unfortunately, they were not as well attended, but the clients who did attend gave us some really insightful and informative ideas and understanding of like what was working for them, what they would like to see, and again helped us really understand how the intervention could be implemented in the best possible way to support their success. When it comes to what we learned in terms of factors that facilitate or hinder the implementation of the intervention, really what tended to facilitate was sort of the accessibility of the activities. And when I talk accessibility, I mean things like the cost. So anything that was relatively low cost or really free, any of those activities were really more accessible to the clients. Ease of admission, meaning things like, where they didn't necessarily always have to bring, say, ID to engage, because sometimes clients didn't have that type of identification, and also accessibility in terms of location of the activity. So anything that was close to home, particularly sort of walking distance, or maybe bus, but one bus versus multiple was a lot easier for clients to access. So the flip side of that being the barriers. So again, cost of activities, anything that was of a relatively high cost, unfortunately wasn't very accessible and clients couldn't participate in. Other barriers included if clients were sort of experiencing mental health crisis and just not in a place where they could engage in activity at that time, or fear of stigma. So feeling uncomfortable going to an activity altogether or alone, just being afraid of being stigmatized by other participants at the activity. In terms of the formative evaluation, we also really wanted to get the perspective of the case managers regarding sort of the materials that were developed to support the implementation. So including tools such as the manual and the community asset map, and also the training that were offered. We were glad to hear that they were found to be sufficient to support the implementation of the community building intervention, and also appreciated as it was something that the case managers could use and leverage to help them throughout the course of the implementation. We also heard that case managers enjoyed the community practice and the opportunity to learn from each other, share their experiences, and help each other out when it came to finding maybe some new and creative ways to help their clients engage with their community. And then we also heard that sometimes, the case managers appreciated the opportunity to build something like community intervention a little bit more formally into the work that they were doing, because a lot of them may have, had it on their radar or were trying to do it in addition to all the other work that had to be done. So having this sort of, formal opportunity to bring it into their work was appreciated. In terms of the client's perspective, when it came to the implementation of the intervention, what we heard from them is they liked the community building process. They liked and appreciated the opportunity to engage in activities and have that chance. And what we were finding is that it gave them an opportunity to connect with new people and just get a little bit more comfortable in their community. They really enjoyed the opportunity to just have a good time and do something that was maybe fun, and building those connections to the community, which I'll speak a little bit more about when it comes to the results and the outcomes from this project. So that brings us into the outcome evaluation. So the difference here from the formative is that with the outcome evaluation, we really wanted to know what the results were of the intervention. So what changes did it maybe bring about for the clients who participated in the intervention itself? So to help us, get this information, we conducted pre and post test assessments with clients. So we met with them at the beginning of the intervention, conducted a series of assessments, did the same assessments at the end of the intervention, and compared the results over time. For the post-test assessment, we also conducted a brief sort of semi-structured interview. So we asked clients some questions about their experiences with the intervention and what they experienced as a result of the intervention, just so we could delve a little bit further into what those experiences were and help us sort of contextualize the information that we were getting from the assessments. I won't go too much into the sample of participants, but maybe just to mention that at the end, we had 16 individuals, 16 clients who participated in both the pre and post-test assessments. We were able, thankfully, from these individuals to sort of gauge what impact the intervention may have had on their lives, and specifically around areas such as like quality of life, well-being, connection. So what we found from starting with just the assessments themselves, so that more quantitative piece, we found that there was a statistically significant improvement in participant recovery scores. So that was interesting. I think I found it interesting and positive. It was nice to see that there was this area where we could see quite a significant improvement. We did also see some positive changes in other areas of the clients' lives around things like quality of life, loneliness, social supports, psychological integration, and citizenship. But those results were maybe not as pronounced. So while the changes were good, they were positive, they were moving in the right direction, they weren't necessarily as strong as when we were seeing changes around recovery. And so to help us better understand these results, this is where the interviews and the results from those interviews kind of come into play. So when chatting with the clients and asking them about their experiences, what we really heard from them in terms of what they gained from participating in this intervention was, again, that opportunity to meet new people, and then making new connections with individuals, whether they were in their building, in the community, or in an activity in which they were participating. We also heard that they were able to strengthen existing relationships with friends, family, but that they were also able to build relationships. So not only did they, for example, meet new people in these activities, but they were also able to build relationships with some of these individuals. So go beyond just sort of a meet and greet and sort of a more acquaintance type to actually building some friendships with some of these individuals. As a result, some of the clients spoke about they were able to gain self-confidence. They became more clear-minded, so they had a better sense of like where they were in their lives or where they wanted to go. And in some cases, they also experienced decreased substance use. So that kind of ties in with that. We were talking earlier about the recovery score on the assessments. What was great too was when we spoke with case managers about the changes that they observed in their clients, we really saw this really nice complementary observations from the case managers. So they did observe, that their clients were making more social connections, that their mental health had improved, that they had increased motivation to improve other areas of well-being, and that they had increased sense of responsibility and pride. However, it should be noted that some clients did not really experience too many changes throughout the course of the intervention. For them, it really came to as a result of feeling anxious about meeting new people, continuing to be sort of self-isolated, maybe not ready to go out into the community, or being preoccupied with more pressing matters in their life that they had to deal with first before they could focus on building their community. But in some of those cases, those individuals were interested in community building. And so while they weren't maybe ready at the time of the intervention, it's still on their radar for the future. So I'll turn it back to Christine now to talk about the toolkit.
Awesome. Thank you, Elise. So based off of our, our project, our intervention, we have created a community building toolkit that outlines the process of implementing this intervention with additional housing programs. So the toolkit can be used by frontline workers, managers, or administrators. It gives an overview of the introduction of what this intervention is, so the background of it. It gives guidance for implementation, and it also provides an overview of how you might go about evaluating it in your own program. So there's some information on the research literature as well as a step-by-step practical guide for using the interventions with clients, which I'll go through a little bit today. So one of the main intervention components was a community asset map. So the toolkit provides a link to the community asset map that it's an asset map of all different activities that can be found in Ottawa. So there might be folks on the in Bright Ideas today that are not from Ottawa. So the toolkit also provides an outline about how you might go about creating a community asset map in your own region. So you can look through ours, you can see the kind of things that we include. So this could be baking classes, it could be, what times the museums are free. It could really be, there's over 200 different activities that we have listed in the community asset map. So it's a great resource for case managers and clients to use. Okay, I kind of talked about that already. So in terms of the actual sessions, the community building manual provides outlines for sessions. And these outlines they're just a guide on how you might go about implementing the intervention with your client. So they're very flexible. That's something, that we heard from our needs assessment, from our developmental evaluation, where, in order to work with your clients, you need to have a flexible approach. So these sessions are a guide, and you can kind of pick and choose what makes sense for your particular client. So there's 4 session outlines in total. The first session is an overview with the client of what community building is, and really trying to get at a client's strengths and what they're doing now and what they might want to do in their community. So what we've also learned from the research literature is that providing support and increasing motivation is really key to engagement. So trying to troubleshoot different barriers that might come up while keeping clients motivated to participate. In the toolkit, we also have some documentation forms after each session. So if there's if you're looking to evaluate the intervention, if you would like a way to document what you're doing, after each session, you'll see these little documentation forms that you can use in the documentation with your client. Community building session 2 involves a review of the community asset map and discussing potential activities with clients. The purpose of this session is really to show that there are a lot of opportunities out there, and it's really up to the client to choose how they would like to engage, whether they'd like to, enroll in like a class at a community center with the city in Ottawa, or if they would just like to do like a drop-in session or go walk around a museum. Any way that they would like to participate is great. And then we start discussing barriers and facilitators. So maybe, a barrier for a client could be that they don't have bus tokens, right? So we're trying to think about what are the things that are really going to get them to be engaged in the intervention. This is just another documentation form. Session 3 involves continued problem solving. So in the toolkit, we have different potential conversation blurbs, examples of how you might overcome different problems that clients are having, and really, going back to what are those clients' strengths and how can we leverage them to help them with their engagement in their activities. And then Session 4 onward occurs while the clients are attending their activities. So the purpose of these sessions are to monitor their progress and troubleshoot any difficulties as they arise. And then discussing, positive and negative experiences the clients are having while attending, just to see if there's anything, that you can do as a case manager to help support them in strengthening their community building. And one more documentation form there. We do have a couple of other additional intervention components that are listed in the toolkit and really described in detail. One of those is a group support. So having the opportunity for all clients, in your organization who are doing community building to come together and talk about how that has been for them. So really kind of like a peer support model. And then the second is through a community of practice. So this is kind of like the group for clients, but this is for staff to come and share, what are the challenges that are coming up, and really troubleshooting and working together to help clients achieve their goals in the community. So in terms of the evaluation, we have a number of measures listed in the toolkit that might be helpful if you wanted to evaluate your efforts in community building, and I will circulate that toolkit right when we're done so you have all of these. Okay, so that is everything for today. So I'll stop my share.
Thank you, Christina and Elise. The improvements in recovery are really impressive considering it's a pilot in a short time period. Thank you for sharing. Thank you for producing all of those tools as well. And now we're welcoming our colleague, Dr. Konrad Tchaikovsky, Assistant Professor at the School of Psychology, University of Ottawa, as well as Dania Versailles, Clinical Director at CMHA Ottawa, to speak about an evaluation that was conducted with our DEI committees.
Hello, everyone. So what I'm going to do is I'm just going to start by sharing my screen. And Marianne, please let me know. I'm going to full screen. I have 3 monitors going, and so sometimes things get a little weird.
Okay, we see the version with your notes.
With my notes. Okay. Then we're going to remove 2 monitors. Give me 2 seconds.
Your slides look great.
Thanks. All right. Now it looks normal.
Perfect.
Okay, great. Okay. Yes, thank you for the introduction, Marianne. This is going to be a presentation about DEI initiatives at CMHA Ottawa, generally speaking, and it will primarily focus on a project that I had completed last year. Dania will then continue to speak about how the project has continued a little bit after in terms of the recommendations and also some other initiatives at CMHA Ottawa. So most of this presentation will really kind of focus on that one project, and also highlight some of the recommendations that we produced collaboratively with the different committees that we had worked with. But first, I'll speak a little bit about DEI initiatives in general. So DEI initiatives and community mental health settings, there's really kind of 2 components to it. So yeah, the idea of diversity, equity, and inclusion initiatives is that they create safe spaces for both employees and for clients. So sometimes we might have certain initiatives that focus on the experience of employees, and sometimes we focus more on initiatives that might focus on the experience of clients. And so a lot of the time, for employees, we might provide training. We might provide training for how employees might be able to support clients from equity deserving groups as well. And so we kind of think of those 2 lenses. And CMHA Ottawa, part of their mission and their goals is to champion diversity, equity, and inclusion within their services at the organization. And so that kind of led to this project. So the project that I completed last year, I had completed under the supervision of Christina Mushler, because I was still, while I was still a student. I also had Sebastian Church contribute to it. Throughout the project, we also worked with all of the committees, the committee chairs, including Helen, as well as Dania, and Marianne as well contributed to our advisory committee. So the goal really here was to, there's 3 DEI committees at CMHA Ottawa: the Anti-Black Racism Task Force, Gender Sexual Diversity Committee, and the Indigenous Committee. And for a while, the 3 committees were doing their work, but they really wanted to have an evaluation to ensure that there's consistency among their goals and their tasks, and to really kind of evaluate what are our objectives, and to kind of work backwards to determine how can we actually achieve those objectives, and are we really doing the kind of work that we want to be doing. So like a bit of an overview to kind of set their priorities and their objectives. So how do we do that? We did that via a logic model. So traditionally, a logic model is a way to illustrate how a program works. So what we did was analogous to a program. We figured, okay, we're going to consider these committees, the committee work, as a program. And as you can see at the bottom of the screen here, generally speaking, in a program logic model, you have outcomes, so the goals that they want to achieve. And then what do they need to do to actually achieve the goals? What activities do they need to complete? What kind of resources do they need? And so we kind of took that framework and I held a number of consultations with the committees, sometimes with smaller groups, sometimes with larger groups, and in very close consultation with the committee chairs to really get an idea of, first, what are your goals? What do the committees actually want to achieve? Long-term goals, short-term goals. We workshopped all of that. And then we kind of work backwards to think, okay, if these are your goals, what do you actually need to produce? What do you need to actually do on a regular basis to achieve those? What activities do, regular meetings, what yearly activities do you want to make sure that you're doing? And then what resources do you need? And that also includes what kind of time commitments do we need from people? So when people join these committees, just so that they have a very clear idea of what some of the expectations might be, to ensure that everything is running smoothly. We identified a few priority areas. So one of those priority areas was general committee functioning. So really just getting down to the basics of how often should they meet, ensuring that there's that the meetings are very purposeful. It was important for them to be able to advise HR on recruitment processes. So how can they actually go ahead and do that? How might each individual committee go ahead and do that? Staff training and support was another priority that we collaboratively identified. So this idea of ensuring that the committees have a role to play in selecting and confirming the different types of training that's necessary, and especially training that can help staff support clients of equity deserving groups. And folks really wanted to work on this repository of resources, so that eventually if somebody has a specific issue with a client that need a little bit support about, or some more information about, what they would then do is, well, we know that we have this resource in a repository, so we can send them that way. And also data use came up a lot. So it's really important for the committees to ensure that a lot of the work that they do is backed by data or informed by data. So they really wanted to have a look to see what kind of data is CMHA collecting right now related to DEI. Can we use that data to ensure that the client population reflects the broader community? And maybe, and if it doesn't, how can the committees work to make sure that we have sufficient outreach to certain communities that maybe are not being served by CMHA? And how can we evaluate that in an ongoing, regular, meaningful way? So that was also a priority, and we had a pretty close look at that as well. Here we have some recommendations. I'm just going to go ahead and highlight a few recommendations, and soon I'll be handing things over to Dania. So I'm going to stay at this kind of general, rather unspecific level, and then Dania will be able to provide some more illustrative examples of how some of these recommendations were then followed up on. Certainly one of the recommendations was to formalize and support DEI work. So there's a number of different ways that we can formally recognize and support DEI work. Stuff like ensuring that DEI work is reflected in staff progress reports, for example, or ensuring that DEI work is more kind of formally integrated into people's roles. Formalizing committee participation was a really big one, and one that I know that they were working on. So this idea of ensuring that when I started the project, we were working on formalizing the terms of reference, which was a really, really good timing, because it meant that Now, that meant that all of a sudden we can evaluate what are these committees' priorities and can we get them in writing so that when people join these committees, they can see that and have a good idea of, okay, this is what essentially what I'm signing up for, so that everyone's consistently working towards the same goals that were collaboratively developed. We also spoke about regular data monitoring. So this idea of ensuring that the committees on a regular basis are able to evaluate their own work. So this was a kind of a larger evaluation that we did of the 3 committees. And the idea was that committees really wanted to ensure that, sure, maybe every 3 or 4 years, we could do a bigger evaluation like this, but on an ongoing basis, what are almost like mini evaluations that these committees can do to look back at the last year or the last number of months and say, these are the things that we thought we could achieve and we wanted to achieve. Were we able to actually go get to that point, and how successful were we? I've made a few highlights here, and I'm just going to hand things off to Dania now. And Dania, please let me know if you want me to stay on this slide or if I should just move on to the next one.
Actually, you can move on to the next slide. Thank you.
Sounds great.
All right. So I decided to start with dessert first, because I didn't know if we were going to run out of time. But what I wanted to show is proud work, work that we're really proud of here. And if you come to our client space on the second floor, you will have the delight surprise of seeing our murals, which these are a mini representation of them. And it's artwork that were created with funding that we obtained to hire local artists who represent the 3 equity groups that Karen has been talking about that we have here. And the idea was with the artists for them to integrate inputs and actual effort from clients who identify with these equity groups to do the work. And so on the left-hand side, the painting that you see here was represented by the Black Anti-Black Racism Committee, the Black community rather. On the top right of your screen, representing the gender diverse community, and at the bottom, the Indigenous community. As well, at the very bottom of your screen, this is more of a recent development. It was tiny, but I think, I know it's impactful because I've received positive comments on it. In our signature recently, our communications and engagement, community engagement manager has reflected these communities in the logos, in our logo that you see here at the bottom. So yeah, so before I move on to the next slides, I wanted to mention that with regard to the progress made, that for all the 3 committees, the priorities that were articulated in the logic model were integrated into our DEI work, and also and this gave us the benefit to articulate well and represent well the priorities of these communities during the recent strategic priority work that we needed to do recently, because it was we were due for its revision. Also, as Conrad alluded to it, we standardize our terms of reference for all 3 committees. Standardized, but yet we still retained the unique flavors and areas of focus for each of these communities. And as Conrad mentioned, the goal was really to cater to the needs of our clients and also of our employees through this work. Also, a decision that we adopted across these teams, these committees, were the decision to offer one training per year for each group, for each committees, mandatory, to make them mandatory rather. And I'll talk about this next. But before we move on, you mentioned data. Data is really, really important. And what we also decided was to develop data stories as the work is happening across the committees. So I know that the data story will be the data story work will begin this summer and move on to fall, etc. And this will become a regular part of the reporting that we need to do, and also monitoring with the different activities that the teams will have put on their dashboard to do. You can go on to the next slide. And so for the Anti-Black Racism Committee, as I mentioned, we actually secured funding to provide the mandatory training. And the one that we selected is one that is research-based and created by the Vulnerability, Trauma, Resilience, and Culture Lab from the University of Ottawa. It's called Providing Anti-Racist Mental Health Care. And we were able to, with additional funding that we secured, hire a consultant whose photo you see on the right side of your screen with the on the poster with the yellow background. And this consultant, Miriam, is helping us through the delivery of this training. It is a self-directed training, but she will help us with offering sessions where staff will be able to discuss what they've learned through the modules and translate what they were learning into the work that they do. She's consulted with many different teams here within CMHA to understand the work that they do in order to help in that effort. And this training was introduced to our staff at an all-staff meeting back in March during the Ottawa Black Mental Health Week, which is the first week of March, following the Black History Month. And at the bottom right-hand corner, you see the original team, the original committee, the Anti-Black Racism Committee. You can move on to the next slide, please. And for the Gender Sexual Diversity Committee as well, they've selected a mandatory training, which is called 2SLBGTQI+ Inclusive Practices, which will be provided by Around the Rainbow from Family Services of Ottawa. And in our June all-staff meeting in honor of Pride Month, we will have a representative of Kind Space who will come to talk to us about the services that they offer to this community, and also provide some staff education. And they're also planning to organize a Pride Month themed art for all in collaboration with their peer team as well internally. Thank you. We can move on to the next one. Oh, I'm sorry. Go back, please. The picture that you see here is a picture of some of the former and existing member of the Gender Sexual Diversity Committee, and at a recent parade that we joined in. It was lots of fun. Thank you. And the Indigenous Committee is our most senior committee in terms of being the first equity committee that we had here. We've been having at CMHA. And so as the other two committees, they've revised their terms of reference and their work plan with a focus on reconciliation and staff education. And so I can say that we've had a lot of Indigenous education for our staff, and currently they're preparing for what we will want to offer during National Day for Truth and Reconciliation in September. And so what I do need to mention and applaud really is their how they were able to develop great relationships with the Indigenous community over time with our community partners. And here at the bottom of the screen, you see different staff members. We held an activity, I want to say back in 2023, in the fall, on Truth and Reconciliation Day, or the day before that, actually. And it was at a park. We had smudging and other relevant activities. It was lots of fun. And if you notice, we only pick sunny days to do our activities. So I'm sure there'll be more sunny days coming because we have a lot of training coming up this spring, summer and fall for CMHA. And so I wanted to really wrap this up by mentioning how important it is to seek the support of management, the leadership at different levels for any of the DEI work that you think of engaging in or you're planning, because it's a lot of work without their support, and it really elevates or it really brings a different level of capacity and energy in our capacity to move the needle, to move the needle and advance the projects, the visibility, our capacity to really provide culture-based services and care to our clients. And so the other thing also I wanted to mention is the importance of ensuring that you seek the capacity of a data person, resource, or department or team in order to help showcase and capture the progress that's being made in this type of work. And so that's what we have prepared for you for today, Conrad and I. If you go to the next slide, you will see our email address should you have any more questions for us past this session.
Thank you, Conrad and Danielle. What a great example of how the recommendations from evaluation flow into the ongoing improvement in our work. So we're going to flow into the final two presentations. They're 2 5-minute presentations. And if we have time at the end, we'll take the final questions and answers, or we will answer them following Bright Ideas in a follow-up way. And perhaps this is a better way to do things because the next presenter, Sebastian Church, his work was very directly linked with Conrad's work as well. So I welcome Sebastian Church from the Faculty of Science, Carleton University, to share his findings.
Hello. Can everyone see my screen? Is everything showing well?
We can see your screen, Sebastian. I think you have to still say that you're put it in presenter mode, if possible.
Well, I just have it in PDF. I
That's
lost
okay.
the other file, but
That's
so
okay. Go
I'll
ahead
begin
like
with it.
this.
But yeah. So hi everyone, my name is Sebastian. I'm a second-year student at Carleton University in a Bachelor's of Science and in neuroscience. And last summer, I did a review of DEI training resources for CMHA Ottawa. And now we'll go over what I did last summer. So first, we'll go over the purpose, then the methods, the results of the search, and how the knowledge is being used currently by CMHA and how it will be used in the future. So the objective of this summer project was to expand the organization's DEI training materials and resource database. And the first research question was, what are current best practices in delivering DEI training to staff in a community mental health context? And what are examples of evidence-based DEI training practices in community mental health? The second question was, what are resources CMHA Ottawa can use immediately to provide staff with anti-racism training? And the third question was, what are resources CMHA Ottawa can use immediately to provide staff with training on Indigenous matters? And the fourth question was, what are resources we can provide to staff with training on sexual and gender diversity? The fifth question was, what are recommendations for training resources that other agencies have found useful? So for the methods, we did 4 different searches. The 4 searches were based on the first 4 research questions. So the search databases that we used were the University of Ottawa Library, the Carleton Library, and Omni. We excluded books and included articles that were published between 2014 and 2024. Different websites were also consulted during the search, such as the Homeless Hub, Mental Health Commission, College of Social Workers, and the Registered Nurse Association of Ontario. In search 1 and 2, 6 articles were chosen in each. In search 3, 5 articles were chosen, and in search 4, 4 articles were chosen. We were not able to go to the 5th one to find resources from other associations, unfortunately. Yeah, and then for the source selection criteria, I first reviewed article titles to determine the applicability and how interesting they seemed. I then examined the abstract of these articles to evaluate how applicable they were and how interesting they were. And then if the title and the abstract seemed applicable to the search, I would then do a detailed review of the article and prepare an article summary and put it in a database for CMHA. So then for the search process overview, we started with broad search terms from each research question, like Indigenous training, DEI training, and gender and sexual diversity training. We then refined search terms by adding specific words or removing certain words to have a more detailed search. So we added words like awareness, education, evaluation tools. And then we then reviewed the search results for each query. And then we noted the total number of results and the number of articles we kept and how different stuff like that. So now for the results. So for the best practices in DEI training for CMHA, there was use active and immersive training like virtual reality videos and simulation methods. And then there was also incorporate mindfulness practice and also implement class culturally and linguistically appropriate services standards. So it's a national guideline to ensure cultural appropriate services. Then there was also prioritize leadership and team diversity, which are key equity drivers. And then also there was integrate DEI into curriculum and practices, so inclusive syllabi, local context, and universal design in education. There was also foster critical reflection and training, including discussion, self-awareness, and power dynamics in sessions. And the best practices for anti-racism training were understand historical context, so cover the history of racism and privilege in the curriculum, address power dynamics, so tackle issues of power and internalized oppression in sessions, and also facilitate interactive learning, including dynamic presentations and community action planning. There was also provide tailored education, so train staff specifically on racial disparities in mental health care, and also develop an anti-racism plan, so outline a strategic objective for advancing equity in the organization. There's also evaluate training effectiveness, so measure staff satisfaction, learnings, and attitude changes. And now the best practices for in Indigenous training was to promote cultural humility, so focus on self-reflection, acknowledging land, and listening to Indigenous voices, and addressing historical trauma, including content on colonial history and its impact on mental health. Use interactive learning, again, like videos, skill-based practice. To also emphasize cultural safety, so go beyond awareness and go to focus on cultural safe and respectful care. There's also improve evaluations, so ensure community involvement and track real-world impact, and also leverage of local tools such as Wabano, University of Saskatchewan, Registered Nurse Association of Ontario, RNAO, and other Canadian sources. And then the best practices we have for gender and sexual diversity training were to use short and practical workshops, so focus on identity, sensitivity, and risk like exploitation. There's also offer clear modular training, include history, definitions, and flexible formats. Make it interactive, use group discussions, exercises, and real life examples. Also aim for a lasting impact, so one-day trainings can shift attitudes with the right methods. Also build a basic cultural competence, so improve knowledge, attitude, and skills when working with LGBTQ plus clients. And for knowledge mobilization and implication, as part of the agency's DEI plan, each committee is moving forward on rolling out specific training to staff on each of the DEI areas. This review supported the selection of training. The review is made available to the agency for future planning. Also, thank you. And if you have any questions, please feel free to reach out to my email and or in the comments in the meeting.
Thank you, Sebastian. Thank you for making sure that our training work aligns with an evidence base. And now I'm going to turn to Jonathan Samash from the School of Psychology, University of Ottawa. And John Samash, I'm going to say, has faithfully presented at, I believe, possibly all of our Bright Ideas events through his doctoral journey. So thank you for all of your work for CMHA, John, and for returning to profile this final analysis that you've conducted for your doctorate.
Well, thank you, Marianne. And I mean, hi, everyone. It's always so nice to be here with you for these events. So yes, I think I have been here maybe from the inaugural one, and that's very exciting for me as well. So yeah, I'm Jonathan Samash at the University of Ottawa, and I'll be presenting just a quick 5-minute overview of research findings regarding outcomes of CMHA Ottawa's Familiar Faces program based on 3 program evaluation studies. So emergency departments are designed to help best for things like putting a cast on a broken bone or stitching up a wound, not as much for assisting with mental illness or addiction. And we know that a small group of emerged visitors with mental illness or addiction make up a disproportionately large amount of total emerged visits, partly because these individuals don't know where else to go, maybe there is nowhere else to go, and also partly because their concerns aren't really managed when they do go, which leads to repeatedly visiting emerge looking for help, but to no avail. This also leads to increased healthcare costs and longer emerge wait times. So the Familiar Faces program here at CMHA Ottawa receives referrals from Ottawa area hospitals for frequent emerge visitors presenting with mental illness or addiction. The program then offers system navigation support to help connect these clients with needed services like help finding a GP, referral to counseling supports, anything like that. And clients requiring more assistance can also receive intensive case management in the program, including services like teaching coping skills, coordinating appointments, some degree of counseling, anything like that. And the purpose of all this is to help these clients get the help they actually need while reducing their frequent emergency department visits. So our first study of the Familiar Faces program investigated effects of the program on client functioning and symptom severity. To do that, we had about 60 program clients fill out symptom screening questionnaires at program intake, and then again after they had been in the program for at least 6 months. We found that clients reported improvement in their overall functioning and reductions in the severity of their anxious and depressive symptoms. Our second study then assessed how Familiar Faces clients experienced their time in the program. For this study, we interviewed 15 clients with a broad range of experiences of the program to see what it was like for them. Clients reported all kinds of positive benefits of the program, indicating that it helped them with mental health concerns, but also more broadly that it helped with all kinds of other aspects of life, like interpersonal relationships, employment, housing, self-confidence, and more. And clients particularly highlighted that the most significant variable that promoted this positive change for them in the program was the therapeutic relationship they developed with CMHA staff. Finally, the third study investigated healthcare service use of about 300 clients in the 1 year prior and 2 years after their entry into the program, including variables like number of emerge visits, hospitalizations, and psychiatric outpatient visits. To do that, we obtained client healthcare records from the Ontario Institute for Clinical Evaluative Sciences, as well as healthcare records for 3 comparison groups, meaning other people who were also frequent emerge visitors, but did not receive Familiar Faces program services across all of Ontario and in the city of Hamilton and in Ottawa. We found that clients experienced reductions in number of emerge visits and hospitalizations over time. But really the big difference between program clients and the comparison groups was that program clients gained much more access to psychiatric outpatient services. So those are encouraging results, showing that the program was helping clients gain more access to the help they need out of hospital, rather than just repeatedly visiting Emerge. So looking at all three studies together, the Familiar Faces program, including system navigation and intensive case management supports, was associated with positive client outcomes related to symptom severity, healthcare service use, and quality of life. And I had the real privilege of meeting many program clients throughout this research, and many spoke very highly of their time with the program, including that they felt it genuinely helped save their lives. So really a testament to the work you do here at CMHA Ottawa. And as always, it's so meaningful for me to be here with you for an event like this. Thank you.
Thank you, John, and congratulations on submitting your thesis for defense last week. We look forward to hearing about your graduation. So we have time for, I think, one question. We have a question in the Q&A box, and I'll turn to Mick and Marcella to answer it. So the question is about how we respond to hoarding situations in housing first, as many clients get evicted for this issue.
Ooh, that's a really, really good question. And I think we can answer it in a variety of ways. I have the benefit of also having Mick here with me in the same bubble. So maybe we will tag team. Hoarding in general is exactly a very common thing that we see for folks. I think the way that I have viewed it in my perspective as a worker is that a lot of our humans are coming from unsheltered environments where survival is the number one most important thing. And when you're in survival, resource guarding and making sure that you have enough things to feel comfortable in survival is important. So that transition of going from unsheltered to housed and bringing all those belongings is really natural. So I think a lot of the time I spend invalidating that process and spending time exploring what it means for that person, if that's the ideology of the belongings or if not. And then either exploring their openness or willingness to build from there, should the hoarding be something that is uncomfortable for them, that all of a sudden it's been a couple of months and they're acknowledging an impact on their wellness because of the fullness of their home and what we can do together with that. So either contracting me to explore that, or we might look for external referrals. There is a hoarding assistance team who's incredible out of options that we often will partner with to explore these things. They've got a 16-week course that they support individuals to go through, as well as one-on-one case management afterwards to deal with the actual hoarding. So their model is education and then action, which ends up being really supportive for most folks. But it's an ongoing conversation, especially when hoarding directly impacts somebody's ability to have safety in their home in terms of fire safety or egress, right? Those are the number one things that we typically think of when it comes to hoarding at a certain point.
Mm-hmm. I also think of the impact on tenancy. So that is one of the ways that tenants tend to be evicted. We also the options team also sometimes runs a small working groups in common spaces in some of the OCH buildings. Some folks have found that useful. I've also worked out kind of practical arrangements with particular clients. There's someone that who struggles mostly with disposing of things, and we've arranged that whenever we have a meeting at their place, I'm holding a garbage bag that they fill while we chat. And then we end the meeting by walking out the door and getting rid of one bag. So then we're practicing that muscle of one garbage bag a week as we chat, and we kind of integrated that into our meetings. It's a tough one. It's something that often we'll recognize before a person moves in. They may be hoarding in the shelter as well, or on themselves, collecting things and collecting bags. So it can be something that's chronic, that's long lasting, and that's challenging for folks to work with or work on.
With lots of things, what we want to focus on is the humanness of the behavior in the first place, right? A lot of our humans are used to being stigmatized for things that are just so naturally them. So it's about exploring what this means and making sure it's unique to that person too.
Thank you. Thank you so much, Marcella and Mick, for such a thoughtful response. This brings us to the end of Bright Ideas. I just have a couple closing remarks. if you do have any burning questions, then we will answer them in follow-up ways, such as through a feedback survey, or you're welcome to directly contact any of the presenters who shared their email addresses in the presentations. So everybody who attended should receive a link next week where we welcome feedback on this event. So just to acknowledge everybody involved in today, thank you to all of the presenters today for your contributions to these fields of research and also your contributions to supporting CMHA's programming. Thank you to everyone for attending, for supporting community mental health research and services. There are a lot of community mental health research gaps and gaps in our homelessness services research, and working closely with community, continuing to strengthen how we work collaboratively really is the best way to address these research gaps. Through our community-based research approach, it's important to acknowledge that the evaluation and research questions in these studies largely come from our CMHA Ottawa community. So for example, staff, peer advisors, community partners will sometimes raise trends that they're observing in the community, and then we'll follow up with a deep dive into looking further into these trends that are being observed. Or like Full House or social prescribing community building, we'll develop and pilot a new program or adaptation, and then we'll need to evaluate how effective it is so that we can expand it. Or there's a training gap like discharge planning, or an information gap like the cognitive effects of opioid use that are highlighted by our community and will come alongside the community to conduct research in that way. So I want to thank our staff and peers who ask these important questions based on their drive to support the people we serve and to continue to improve what we're doing here at CMHA. I want to give a shout out to Patrick Jodouin, who made this event happen behind the scenes, to our decision support and accountability team who organized the event, to Donna Petty, who again, I hope was watching as a participant on the screen. This work happens because of her decades-long commitment to research and evaluation at CMHA, and her and Tim O'Brien beginning a partnership many years ago that have brought us here. Looking towards the new year, we have some new research and evaluation initiatives on the horizon. In partnership with CMHA Toronto, we're building our capacity to have peer researchers as part of our research teams. We're also part of some innovative student learning initiatives at the University of Ottawa, where students from different disciplines, including engineering and health sciences and social sciences, and then across other institutions as well, in addition to the University of Ottawa, come together to tackle wicked problems like homelessness. And we continue to strengthen the way we integrate the findings of studies into our everyday work. So thank you again, everybody, for joining. You'll receive a link to the feedback survey, and enjoy the rest of your day. Thank you, everyone.